我做过，对，嗯
Hello, Dr. John.
Hey, Juma, how you doing?
I'm fine. How are you?
Good. Yeah, you obviously can hear me okay, right?
Yeah, I can hear you okay.
Okay, you're on your phone today?
Yeah, there's a resident. I think I already informed him. I think we're logging now. He's the
Okay,
one who's going to present.
okay, who's gonna present?
Uh,
Guido
his name is
or Fahar?
no, is Dr. Amte and the Sengua.
Okay, I'm gonna give you administration rights and you let the person in.
Yeah, sure,
Okay,
sure. His
yeah.
name is Sengua and Amte. So how about Aip? Should I text Aip or you already text him?
No, Ike's not here yet. Hang on.
Should I call you?
No, he knows. I'll call him. Oh, if you
Okay.
want to, that's fine. If you want to, that's fine.
I'll just text him.
Okay. Okay. You need to come in, the panel, you know, accepting the
Again?
panel. You
Okay.
need to come into the panel, okay? Yeah, there you go, okay. And I guess I need to just put my face there. Um, There's I. How you
John,
right?
can you hear me, John?
Yeah, I can hear you. I can't see you.
Uh, 1 second. I'll just get the video going. One
Okay.
second. What time do we start, John?
About 5 minutes. We can
All right.
start. We can wait a few minutes.
Hello, Professor Ipe, how are you?
Hey, Juma. So good to see you, man. How are you?
Me too. I'm good. It has been a long time.
Yeah.
I can't see
So,
either of you guys.
so
What do you
Senko
mean, good to see you? I can't see you.
Well,
There you go. You're out there, right? There you go.
there has
yeah.
been a lot of
That's a
holidays here.
nice background. Who's in the background?
That is a child god, living child god in Nepal. She's called the
Yeah.
Kumari. It's a painting of her.
Oh, okay. Colorful. Well, that's great, Ike. You got something lined up for Zambia and the robotics, right?
Yeah.
Yeah, the robotics one is I fixed the date. You have the 26th. It's the 27th, the Saturday. But you had
Off.
you had it on the 26th, but it's the
Yeah.
27th. It's the 27th.
Yeah. Yes. Do you remember about our meeting on August? I can see Fajal also. Good to see you, Fajal.
Good to see you, sir. How are you, sir?
Absolutely good. I'm coming to Malaysia, Borneo in September. We're going to have a large microvascular anastomosis meeting along with the
Oh,
NAMS meeting, the Malaysian national meeting.
great to hear that, sir. I hope I can participate.
Yes.
You're in Malaysia, huh?
Beg your pardon?
Yeah, you're in Malaysia. The gentleman that came in later, Fahak, you're from Malaysia.
No, I'm from
Your voice
Indonesia.
is breaking, John. I mean, your voice is breaking. I mean, I can't
Oh, really?
really.
Really? Okay, hold on. Okay, still breaking, testing one.
Better
two.
now, better now.
I don't know, okay. Mhm. Okay, Juma, so what are we gonna do? You're gonna introduce, okay, I'll introduce you and then you introduce.
So they,
Okay, go ahead, Juma, go ahead.
so I called Dr. Amtei and they said they are logging in. So I'm waiting for them to
Okay,
log in as well. Yeah.
okay, as far as structuring the program, I'll just introduce Ike, and you could explain why you're doing this, basically.
Yeah, so I
Oh,
thought there are many videos of ours, basilar tip clipping on the YouTube, but what I thought is I'm just going to tell them what does it, what, what does it for a surgeon to clip? I mean, how are you going to clip? Easy cases, difficult cases. So I'm going to show probably a dissection and then I'm going to show a video of how we're clipping.
okay, shall we do the presentation before or after?
However Juma wants, it's fine.
Shuma, how do you want to work it? Do you want your
Okay.
associate to present his case first? Or do you want to have
Uh,
Ike go first.
I wish we could present ours, then I can present his. And
Okay,
then we can
okay,
learn from the
okay,
what is he thinks, and he can show maybe a similar case.
okay,
Let me call them back again, but I think they are logging. Let me call them back.
okay, okay. Don't worry, we got time. Oh,
John,
yeah.
we got some few things coming up. So August 16, 17, 18, and 19, we have our meeting coming up.
Oh, okay.
Uh,
The big one, huh?
in Karad, yeah, big one. Luis Borba will be coming there, the president-elect. And well, we've got after that we got Sam's meeting coming up. Before that, in June, I'm coming to Turkey for Yasbul's meeting, 75th anniversary or something. So I'm
Oh,
coming
really?
there.
Yeah.
We will be. Sanma is also coming there. And
Sammer?
then we also have a meeting in June in Kerala. This is cadaver dissection. Then we have Malaysia, September 12th, I suppose. It's a national meeting, the Malaysian national meeting. So we're going there as well. And of course, October, November will be in Russia for again another exoscope workshop. So
Okay.
these are the meetings that I'm committed to right now, and we're working a lot with two companies for artificial intelligence in exoscopes. That is with Sanma.
Oh, wow. Wow. Exciting
Yeah,
stuff.
so it's very exciting, very exciting.
Yeah, if you could put a list type of those and send them to me, or just keep me up to date. Just update me as needed.
It's
Okay, I
like
think,
this, John. I mean, I always don't respect NDAs, so that's the thing. Companies have they don't like me talking about it. But the thing is, what we are working for is that when uh, exoscope sees a particular field,
oh, okay.
the exoscope can kind of realize where it is, meaning this is the optic nerve, this is the cavernous sinus, this is the carotid. That's because it's got a scanned image, phantom, that's reconstructed scan image, and there is an atlas which will, with AI, it will identify what parts of the scan are seen and where are you. So we're trying to bring these three together. So that's AI in exoscope. It's a completely new concept that we're starting in. So basically, even though the surgeon may not be able to identify where you are, the exoscope is going to tell you where you are. And maybe sometime the exoscope can give you a line for an aneurysm clipping or a tumor removal, how much tumor you can remove safely before you get into trouble and things like that. So this is what we are working with. Very exciting, actually.
Okay, John is here. John, you here? John Matai, Dr. Matai? Can you hear me okay? He's here.
Hello,
Hello. Yeah, hi, Dr. Matai. Can I see you? I can't see you. Your
I
camera's
can hear
not
you.
on. Yeah, your camera's not on. Can you turn your camera on, please?
Thank you. Yes, we are here with
Okay. Yeah.
Dr. Magogo and the rest of my team.
Can you put your camera on? I
I
can't
have
see
here
you.
Dr. Sengua, who is the resident.
I can't see you, Dr. Matai. Could you just put your camera on, please?
All this time.
There you go. Okay. Okay. Are you
Can
going
you
to sit
hear?
down?
Can you see me?
Yeah, I can see you. Are you going to give a
Yes.
standing presentation? Are you going to sit down or give a standing presentation?
Okay. Okay. I'm in a classroom with my residents.
Okay. Okay. You have, okay, we need, are you going to sit down or are you going to stand up and give the presentation? Okay. Okay, I'm going to have Dr. Juma is going to introduce you, Dr. Magogo, okay?
Yes, sure.
Okay, just a minute. Okay, 10, 9, hold on. I gotta put it live. I have it live. Make sure it's working live. Yep, it's looking live. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett, broadcasting from the home of Neurosurgical TV. We have Tanzania Grand Rounds, a regularly scheduled program that I'm Cherian, well-known neurosurgery educator from Kerala in India, oversees the broadcast, and Juma Magogo, the Tasmanian neurosurgeon locally, is going to introduce his resident, Dr. Mubai, who's going to give a presentation. Okay, Juma, could you please introduce Dr. Mubai, please?
Yeah, so thanks so much, Dr. John. It's a honor to introduce Dr. Mtei. Dr. Mtei is a young neurosurgeon at Moi Orthopedic Institute. He has been more interested in doing skull base and neurovascular. And he has already done some clipping, of course, while assisting the seniors. And he's also into angiography. We have an angio suite where we do the diagnostic DSCA. So he's going to present this case of his that stuck to him. He wants to get opinion from Professor Ipe, the most popular, renowned neurosurgeon in this world, who does a lot of clipping, especially even those difficult ones. So we would like to get the opinion from him. Dr. Mtei, the floor is yours.
Thank you, Dr. Magogo. Here at Moi, you have a patient to whom we got challenging this patient because we have already started doing our aneurysm cases for more than 5 years now, but we're still doing most of the posterior for the anterior circulation aneurysm, the MCA, COM and ACOM clipping. We are not much competent based on the posterior circulation and some of endovascular treatment. So I'd like to share this case of a patient of whom we received 1 month ago. And this case shall be presented by Dr. Sengua. So can you please give access to Dr. Sengua to share his screen?
Okay, I don't understand. You want to go to someone else to finish the presentation?
Yes, can you give access to Dr. Sengua's to share screen?
Okay, is he in the panel?
Yes.
Okay, go ahead. He can present if he's in the panel.
Access.
Dr. Sengua, ¿verdad? Hello? Okay, Dr. Sengua is coming in.
Dr. Sengua, have you already logged in the link?
Yes,
Yeah.
already logged on.
I think he's just getting, okay, Dr. Sengua, are you ready to go? You just got in. There we go. Okay, you need to put it on present. There you go. Thank you, Dr. Very good. We're all set. Can't hear you. You're muted. Dr. Sengua, you're muted.
Can you hear me now?
Now we can hear you. Yes.
Thank you. May I share with you a 44-year-old male whom we received in our hospital 1 month ago. This gentleman was referred from another hospital, which is almost 600 kilometers from our institute. He presented with a progressive history of right-sided weakness, which was there for 2 months prior to admission.
We lost him there. Huh?
He's a non-smoker. He never used drugs like cocaine. So in examination, he was scoring 12 with I4 motor skills and verbal.
Yeah. Hello, John. It might be better if he sends us the PowerPoint because it looks like he's at a computer that's not very strong. Can he send the PowerPoint to us? Dr. Juma?
Let me try to call them. Maybe he has some poor network there.
Yeah, he's probably got a weak connection, which I should have prepared for this. I didn't
Okay.
prepare for it. But he can send us the PowerPoint and we can present it. Do you know what I mean? Because I don't know if we'll be able to do it the other way.
Dr. John, kindly advise how can we send the PPT to you? By email or by WhatsApp? Or...
Either way.
Okay.
Yeah, I'm gonna give you got my WhatsApp, right? Let me share.
I don't have
Okay.
yours, so you can send to me your WhatsApp.
Yeah. Well, send it, we're connected by email, Facebook. So can you send it by Facebook?
WhatsApp will be easier. WhatsApp will be easier for now.
Okay. Okay. Let me see if I got you on, okay, let me give you my WhatsApp. Okay, put in the chat, Juma. Do you see it? My number in the chat, WhatsApp, what number?
On the chart,
Oh.
okay. Let me take it.
You got
Okay.
it?
It starts with +1, right?
Yeah, John Bennett. That's my WhatsApp number. That's what you wanted, right?
I can see Othman Kiloloma here. Good day, my friend. How are you? Othman, are you here?
I'm here. I can hear you.
Okay, good. Good to see you.
Yeah. It's a long time.
Long time, yeah.
How are you doing?
We probably would be coming to East Africa again. I have another fellow from Uganda
Okay.
right now who's spending 1 year with me. So we want to come to one of the East African countries again, maybe Kenya, Tanzania. We want to make a meeting for young neurosurgeons. And last time I came there, I thoroughly enjoyed. We had a great case, and I remember Othman coming with me for the post-op to see the patient.
Yeah. You are welcome to Tanzania, and we are always ready to receive you. We have now a lot of cases. We are going next week. We will have our first Tanzania Neurosurgical Society AGM. Will be on Friday and Saturday, 26th and 27th. So
I see.
yeah, it's a very short notice.
I mean,
but
I would have been very interested to come, but then I had a knee injury, and I'm kind of, I just happened today, so it's a sports injury. So I probably would take rest for 1 week. I guess it'll be okay after that.
When you are coming to East Africa, possible you have to pass. If you are not coming to Tanzania, at least you pass by in Dar es Salaam.
Yes, I would definitely like to come to Dar es Salaam, Zanzibar, and last time I came, I couldn't really visit any places, but this time, the next time I plan, I'll plan for a longer time.
Yeah, Zanzibar is a golden area. It's a must visit. It's a very good place, as well as Gorongoro crater. In
I
Zanzibar,
have to go.
Yeah, it's a place you must.
And I
It's very
welcome you all to India as well. We have a meeting in August 16 to 19, and I hope you guys can come down. I'll tell Juma. It's August 16 to 19.
Okay.
We'll send you invitations, and I'm personally inviting you, Othman. So Juma, Othman, my other friends, because August 16 to 19, this meeting, we'll have a lot of international faculty, including the WFNS president. We will have so this August 16 to 19.
Which city? In which
It's
city?
Karad. The name of the city is Karad, and you fly to either Mumbai or Pune is easier because from Africa there are direct flights to Dubai, and from Dubai there are flights to Pune, Pune, Pune.
Okay.
And from Pune it's 2.5 hours to Karad by car.
Okay. Okay, we will keep in touch.
Yeah, sure.
Thank you.
Yeah. Juma, have they connected again?
Yeah, Juma, have you sent it? I don't get it yet. No.
So yes, I've called them. They are saying they are trying to open through Dr. Mtei's computer.
Okay, because
it's a big PPT because it has some DSA pictures. That's why they cannot share to me directly. But they are coming. They are logging in soon.
Okay. Now I want you to send me the PowerPoint by email, please. Okay.
Okay.
I just sent you you got my email, right?
Yes.
Okay.
No, in the meantime, what I can do is there's some dissections that we had done, or maybe I can just show a basilar clipping, and then from there we can take it forward.
Yeah, that sounds good.
I agree. You can proceed, Professor Saib.
Okay, great.
I'll just share my screen. This is one of the talks. I did it in Neurosurgical TV. So you can see this is the aneurysm. It's a posteriorly pointing aneurysm. So but we found that anteriorly pointing aneurysms are rather not very difficult. And this is posterior pointing aneurysm. So you can see the basilar, and that's the aneurysm. These are the two P1s. This is the superior cerebellar there. And what is the way that you will go? So what we did is here, to going through this corridor, we have to take out the clinoid. We have to free the carotid and go in this optico-carotid corridor. Okay, that's a corridor that you have to go to. And that's not very difficult. But then later in the dissection, I'll show you how we can go completely transcavernous also. So this is a ruptured aneurysm, which had come to us. So we're going to do the clinoid dissection now. So well, that's aneurysm. I'm showing this. It was so we are drilling off the clinoid and then removing the clinoid. You can see the sharp tooth of the clinoid coming out. After drilling and coring it out, I use a needle holder. And then this is a ruptured aneurysm, so recently ruptured. So I'm going ahead and opening the opticocarotid cistern. So that's a PCOM. That's the PCOM. The arrow is on the PCOM. You can see the third nerve. And I'm still releasing the opticocarotid arachnoid. Using the diamond knife to cut a little bit more of the proximal sylvian so that my window gets better. Membrane of Lilliquist is being opened out. And you're starting to see the posterior circulation laterally. And you're going to see the posterior circulation medially in the opticocarotid window. And that's a basilar. Now, the thing is, how do you identify where the aneurysm is? That's where you should look for the contralateral third nerve. Very important to go to that side and look for the third nerve. For the young neurosurgeons, you can see the third nerve there, that's arrow. And that means the artery above that is a P1. So then if you get one contralateral P1, you get the ipsilateral P1, and then you know the aneurysm is above that. So now that, because it's a posterior projecting aneurysm, very, very difficult to figure out in an acute bleed. So you know that there is aneurysm. So now I dissect between the P1 and the aneurysm. So keep on dissecting. I find out the line between the P1 and the aneurysm. It's very important that you don't prematurely apply a clip. You have to keep on dissecting very gently. And here I have no proximal control. You must understand that. I'm not putting a clip on the basilar. I'll go for a direct clipping. So I'm keeping on dissecting from P1 aneurysm junction. Once I have that junction, see, now I can see the junction. I dissect it a bit more. This is very important for young neurosurgeons because this is called patience, and patience is the most important thing. Now, what you can do is you can try to put the clip in, but what you can do is with the clip itself, you can dissect a bit. You put it only as much as you can see it, and then when you apply the clip, you can see what's behind it. The neck generally never ruptures, so it's okay to take off the clip once and then try again. Of course, you should not be fast and rough with your movements. So you keep on holding the neck with your clip, going in, opening, closing, and then going in, and then finally you have the clip there. It's done. So you have both the P1s now, and you, and that's the ICG, which shows that I have completely clipped off you can see the clip, and then there is nothing distal to that. You can see the IC here, and distal to the clip, there's nothing. So this is one case, and then before we go to the other case, I can probably I can show you again. So now the question is, what about basilar clipping? Is it okay to do it by surgery? Here, what I would say is we've got a large number of posterior circulation aneurysm clippings because I was in Nepal, and we did not have any interventional radiologists there during the time that I was there. Now I think they have come in, and so during the time that I was there was not many interventional neurologists, and obviously they were not in the periphery, so we were clipping all the aneurysms, posterior circulation, anterior circulations. So what, for a young neurosurgeon, how can you clip it? Now, I remember John and Juma being with me for a suprabrow removal for a large tuberculum cell meningioma. I would say the approach is the same. That you know, one thing I would ask you guys is to start microneurosurgery for trauma. You have a lot of trauma. You should start understanding what is the extradural dissection technique for getting into the interpedunculair cistern and basilar and all that. So this is what we're going to show you. That's this unlocking is what I want you to understand. This is the temporal lobe. The temporal lobe, and this side is the cavernous sinus. Once you move the temporal lobe away from the cavernous sinus, you have a highway into the interpeduncular system. Okay, There's a pre-temporal, I mean, there's a Japanese technique of pre-temporal mobilization of the temporal, I mean, the temporal or pre-temporal route to the basilar. But here we're going extradural. We're completely going extradural and mobilizing the whole temporal lobe away so that you can get into the, either transcavernous or without the transcavernous technique, you can get into the basilar. So here is, we're going under high zoom, very high zoom, taking off. That's a cavernous sinus. It's an injected cadaver from the Esculap Academy in our institute. That's a clinoid. That's a lining of the superior orbital fissure. So you can remove the orbitomeningeal. You can cut the orbitomeningeal band. You see me cutting that, and then that is the clinoid process. So the roof of the cavernous sinus is being dislodged away from the cavernous, away from the clinoid process, and you can remove the clinoid straight off. This video is available in my YouTube, so you can see once you remove the clinoid, you can see the distal dural ring, proximal dural ring. This is a distal dural ring, it's a post-proximal dural ring. Drilling the optic roof and some part of the strut. So that's the optic roof. So optic roof is being delineated and the strut is being delineated. So that's an extradural, that's an extradural optic nerve, and that's a carotid, that's a cavernous sinus. So you have V2 there, V1 there, 3 and 4 there. So you can see V1, V2, and V3. 3/4. The temporal lobe is completely moved away. And now I opened a Parkinson's triangle. Once I've opened, the Parkinson's triangle is between the 4th nerve and the V1. Once I remove that, then I'm going to see the meningohypophyseal trunk arising from the C5, that's a paraclival and horizontal intracavernous segment. Between that, the meningohypophyseal trunk arises, and below that you will see the petroclinoidal ligament and the petrosphenoidal ligament, that is a Gruber's ligament, and below that you will see the 6th nerve. That's a petroclinoidal ligament, that's a petrosphenoidal ligament, and you cut both and you will see the 6th nerve. That's the 6th nerve. And this is a meningohypophyseal trunk. So I define first the petroclinoidal ligament is cut. You must understand that the 6th nerve is intracavernous. So you, when you go into this, you can have some bleed. Showing the trajectory of the 6th nerve there. Yeah, so you can see the 3rd, 4th, the 6th, V1, V2, V3. Now I'm dissecting the distal dural ring. So the optic nerve and the distal dural ring is freed up. So that's a carotid. And between the carotid and the third nerve, that's a PCP there, large PCP. Once you take that PCP, what you're going to see is the basilar. Not all the cases require PCP removal. Please notice that. I can always put a incision and free up the third nerve completely and cut the tent, cut the part of tent between the third and the fourth nerve. That is the basilar tip coming exposed. So you can see the superior cerebellar. This is the P1. That's the basilar tip. So you ask me if for a surgeon, it's a difficult basilar tip. It's completely clippable. It's not as if this is the basilar, superior cerebellar, P1 on this side. You already saw the third nerve. That's a third nerve between the P1 and the superior cerebellar. Now with a stab incision, you can cut the PCP. And then you can take out the PCP. There will be a lot of venous bleeding at this point. We use a glue, which we make in-house. We use a powdered gel foam, normal saline, a little bit of patient's blood and
posterior clinoid process.
Hello? Can you
By
hear me?
PCP, yes. Do you mean PCP means posterior clinoid process?
Posterior clinoid process. Posterior
Okay.
clinoid. So the posterior clinoid process is being removed now. After you apply this glue, the posterior clinoid process, bleeding will stop and you can remove it. And you can see the entire basilar trunk now. Contralateral third nerve is coming into view. So basilar SCA P1 third nerve. That's the entire basilar trunk. So the contralateral superior cerebellar artery can also be seen. Here I have not gone complete transcavernous, but once I release the third nerve completely and see now, we can go transcavernous here. I'm releasing the tent, cutting the tent between the third nerve and the fourth nerve. There's a lot of guys, surgeons who don't believe in a cadaver lab. You know, only thing I can tell them is if you don't start off with being a cadaver surgeon, you will make cadavers out of your surgery. Okay, you don't want to do that. So either you have to operate big cases or not operate big cases. And if you're operating big cases, you need to be in the lab. There's no question about it. And now we are going to the Kawase, which is not required. Sometimes the basilar can be approached by the Kawase approach, very rarely, but most of the time you don't need to do that. Okay, so I'll stop at this point. And we'll see if, I think, I hope John is ready with Juma is ready with the presentation.
Yes, please.
Okay, Juma, what do you want to do, Juma?
Oh, yes, so they can proceed. I think they are ready with the presentation. Thank you so much, Professor, for the presentation.
Okay, could
You're
you please
welcome.
introduce them, please?
You're most welcome. So I'll just figure out one more video. You guys, please start presenting, please.
Okay.
Okay, who's going to present? Okay. Okay, presentation mode, please.
Yes, so
Perfect.
as I said, we received this gentleman 2 months ago in our hospital who had right-sided weakness, inability to speak, and on and off headaches, which were running for about 2 months prior to admission. However, he had no convulsions, vomiting, and no history of trauma or intoxication. He's a non-smoker. He drinks alcohol socially, and he has no history of use of cocaine or other drugs. So in examination, he was scoring 12, I4, motor 6, verbal 2 on the day of admission. Of course, he later on he was improving, the vital signs were stable, he's non-hypertensive, the blood pressure has been normal throughout. He had normal pupils, which they were both reactive to light and equal. He has normal sensations, but reduced the power on the right upper and lower limb. But on the day of admission, the power was 4/5. So we ran a number of investigations. Laboratory investigations were all normal. Echocardiogram was also normal, but echo showed a little bit of left ventricular hypertrophy. It was mild. Otherwise, it was a good echo. And we did a CT scan. This was the non-contrasted CT scan, which showed a huge tumor-like, it was an aneurysm in the prepontine system. So we had to go ahead and do this CT angiography and cerebral angiography. This is the CTA. I think, can you see this? So this is the CTA. It showed an aneurysm of the basilar apex, which was 3 by 2.6 millimeters, and it had an intimo flap, from the CTA, and sorry. Yes. So it was a basilar tip aneurysm with an intimo flap. So we went ahead and did so the anterior circulation on both carotids was normal, but on injecting the left vertebral artery to examine the posterior circulation, it showed a huge aneurysm at the basilar tip, which measured about 2.6 by 2.6 by 1.3 millimeters. 26 by 13 millimeters, and The neck was 7 millimeters. The posterior, both posterior cerebral arteries and the left is superior cerebellar artery were rising from the neck. So we had a challenge on which method of treatment for this patient. And we thought probably endovascular option like stent-assisted coiling would help, because clipping would be difficult because of the perforators and the origin of the posterior cerebral arteries, the P1 segments of both left and right, and the superior cerebral artery on the left side. So we had already started planning this patient for transfer for any possible endovascular options. But I wanted to share with you because we still have this patient in Dar es Salaam. We have not yet managed to get of course, go out of the country. He was discharged from the hospital. He's just home now, doing well. The power, he can now walk with assistance. The scoring 15 was so. Wanted to discuss with you can really help this patient in our setting because his transfer is also delaying and catastrophe can happen anytime. And given the fact that we have not yet clipped DNA, basilar tip aneurysms, the complexity of the perforators for this one, we'll want to know your views and in this case.
Dr. Magogo?
Yes, I can hear you, Dr. Mtei. You can proceed, please. Just read the
Yes, I
discussion.
think Dr. Sengua has already finished to present. I think you have saw this DSA image and the CT angio images.
Professor Aipa, you there?
Hello? Can you hear me?
Yes.
You can hear me, right?
Yes, yes.
Yeah, so the neck can easily be reconstructed with a straight clip across the neck. You will be able to spare both P1s and superior cerebellars. It's not as if it is maybe 2 clips, or either otherwise you can put multiple clips on the dome, stacked multiple clips, so that you can reconstruct both the P1s and the superior cerebellars. So it should not be a problem. Once you put 2 clips on both sides, then it's just a matter of stacking more clips till the aneurysm is completely obliterated. Endovascular, I don't know. I will not be the best person to comment on it.
So if I get you correct, the technique is to put multiple clips on top.
Yes. So no. Can I show you how to do this?
Okay, sure.
Yeah, I'll share my screen. Maybe go to. I'm going to share my screen on a whiteboard. Can you see? So you're understanding? This is a P1, superior cerebellar. You understanding?
Yes.
Yes,
Yes.
everybody?
Yeah, sure.
Okay, I'm going to put the clips on now. 1 second. So there are two options. One is to put the first clip can be a fenestrated clip. This one can be a fenestrated clip. And this clip, the second clip, this is a fenestrated clip, and this clip crosses off the fenestration. Or you can put clips like this. Let me just show you. Like, this is the most simple technique. One like that. One like that. And then you put clips here, 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 and here. Basically, what you do is, you understanding, Juma?
Oh, yes, yes. You
This
said
is called,
fenestrated clips.
no fenestrated. It's straight clips. All
Okay.
straight clips. All straight clips. It's
Okay.
called vertical stacking.
Okay.
Can you see how you're vertically stacking clips and reconstructing the see? Did you understand?
Yes. 7 clips.
Yeah, but
This
yeah.
way, what you can do is you can define this space in whatever way you want. If you're putting a clip right across like that, you may not be able to define like this. So supposing if there is a branch arising from here, you can just take this clip a little bit away and it will still fill because it's a basilar, it's a end vessel. So you can use this vertical stack to define where any vessel is coming off from anywhere. You don't have a problem. You can still use the vertical stack to completely obliterate the aneurysm while preserving all the other vessels.
Oh, got it. But I think one would love to see it, how you do it. I mean,
Well,
like
you guys call me and I'll come. I think MJ was with me for surgery.
exactly.
Yeah, so he was fantastic. So I'm sure if I show him a little bit more, I'm sure he'll clip one of these. That's no problem. And I think all the guys who was assisting me that day was very talented. And those guys, they were thinking of taking a biopsy, and these guys helped me to take it out completely without any problems. So those guys, so you remember the tuberculum meningioma, those guys were telling us, let's take a biopsy and go. So, and the exposure was suprabrow, but it was a tough tumor, but these guys did a fantastic job. So they helped me with the surgery, and I'm sure they can very well go clip these aneurysms if I show them. And I think you should go ahead and clip it. I don't think there's any problem if you see a few of my videos. And you see, in your country, what you don't want to be second grade all your life. You can start off second grade. Everybody starts off second grade. The guys who came for that surgery those days, and I can tell you, they were nowhere experienced. For me, they are second grade. So for them, they think you're second grade. There's always somebody better. So the best thing is to start off. You have enough cases, you have enough skill. I have seen your skill. So start off. It's very important to start off. Don't think I cannot do it. Don't think I'm not competent enough to do it. You are competent. You have seen, you see the videos, and you have the skill. It's basilar exposure is not very difficult. See a few cystonostomy videos. They expose the basilar in 15 minutes. 15 minutes, I'm telling you. And actually, that is because I'm being humble. If I tell you for a cystonostomy fast, if I'm doing it fast, I take probably 5 minutes. Once the dura is open, I'll take 5 minutes to expose the basilar. So don't do that. Open all the membrane, or go between the opticocarotid window, go between the carotid and the third nerve, open the membrane of Lilliquist very meticulously, and you'll be able to open the basilar. You know, you'll be able to clearly open the basilar and see everything. Then you can put the clip. Okay, this patient, if you don't do it, she's gonna die. So why not that you go and do it?
Thanks for those words of encouragement, Professor Aip. I think we will start now. We're actually happy to do, but I think under your guidance, if you are there sometimes, we will invite you to get more confidence, and then we can kick start. We actually do some of the cases, ACOM, PCOM, MCA, aneurysm, but this one was a bit tough for us, and even we think maybe he probably would benefit from coiling rather than clipping, because we were not sure if we could clip this one.
See, clipping, coiling is not an excuse. Remember that. We are surgeons, okay? We are supposed to go out of our comfort zone. In this case is not easy for me also. When I did my first basilar, it was not easy for me. Many times I thought I was not competent enough. And the complications that I had, I thought maybe I'm not designed to clip this kind of aneurysm. I was in Nepal, you see? But the secret is to persist. Be having the courage to go out of your comfort zone. That's what is neurosurgeon. We are warriors. Okay, so remember that, and I'm sure I have seen enough of you. That boy who was assisting me, I have seen enough of him. He has the skills, certified, no problem. Okay, you guys go ahead, see some videos, and after that, go do this. Okay, don't wait for, if you have endovascular options which are readily available, and they are very okay, and the patient can afford it, yes, but don't keep waiting, and don't keep waiting because you're confused. Okay.
Thank you so much, Dr. Aip. That was so fruitful input. We thank you so much. And Dr. Mtei, do you have anything to add? Any question?
Hello?
Dr. Magogo, can you hear me?
Yes.
Yeah, thank you for the input from everyone. We've started already started clipping some of the aneurysm, and we have I can say we have the outcome is very good for our patient. And because we didn't yet done a single posterior circulation aneurysm, probably we are going to start doing the aneurysm, because currently we don't have the endovascular options in Tanzania for the aneurysm. We don't have stent, we don't have the coil. So we really have to do this.
Okay, I'd like to welcome Takashi Khan. Do you have any comments, Takashi? Are you there? And perhaps he just arrived. There's also Harshad Correct. He asked a question about how do you make the glue? Please explain how do you make the glue? Maybe that's from a long time ago.
Yeah,
That's
so the glue is very simple. What we do is we take a file, something that can powder things. So you take the gel form and you take a file and you keep doing this. You keep brushing this, and then the gel form powder, you mix it with normal saline, and then take a 3-way and connect two 20cc syringes, and from one 20cc syringe to the other 20cc syringe, push this mixture. Okay, keep pushing this mixture about maybe 20 times, and it becomes like a glue. And to that, you have to add fibrillar Surgicel. Okay, you take fibrillar Surgicel and you add fibrillar Surgicel, and then to that, you add 5 ml of the patient's blood. This is the glue, and it is better than any glue. I can tell you this. Okay, it's very cheap and it's better than any glue. We want to publish this, but we have never published. You guys want to go publish this? Okay, publish it, but give some credit to us.
Okay, any more comments, questions from anybody in the panel?
Yeah, thank you very much, if you allow me.
Yes, please.
Yeah. My questions goes to Dr. Singua and Mtei. On your read around for in a center where you have both options, I mean, clipping vis-a-vis endovascular coiling, what's the outcome? Which one is much more easier, has better outcome, and the post-op complications are much more lower among those two in this case? Remember, we have some students on board.
From my reading, the easier option for basilar aneurysms is endovascular techniques. But in terms of outcomes, there is no significant difference in them from microscopic clipping and endovascular techniques. However, the rate of recurrence of the aneurysm is higher in endovascular techniques for the basilar tip aneurysms. So surgery is complex when the perforators from the dome or from the neck of the aneurysm, like the PCA and superior cerebellar artery, if they arise near the aneurysm, then it can be difficult in terms of surgery. So maybe in the very experienced hands, it's possible, but maybe for those for those who have no much experience, I think it can be catastrophic, especially if you have high riding basilar, that the tip is far away from the corridor, so it can be problematic if the dome ruptures. Dr. Mtei.
Yes, Dr. Osman, as Dr. Sengua said, most of this basilar tip aneurysm, I think most of the center is they have their own protocol. In some of the center, they have their protocol that every basilar tip, they do it as endovascular. And in some of the surgeons, they prefer to do it open microsurgical clipping. But in terms of recurrence, the recurrence is more if you do the endovascular, because a lot of things happen during the endovascular coil disimpaction, migration of the stent, and so forth. That has been depicted in most of the literatures. But it's easy to do the endovascular, and even the interventional radiologists can do the endovascular. That's why it's more popular to do the endovascular rather than the microsurgical clipping. But in terms of complete occlusion of the aneurysm, the surgical option is much better to do it. Though there is also some percentage of recurrence to this patient.
Thank you. Thank you very much, Dr. Mtei and Sengua. Dr. Cherian, thank you very much for your kind words and encouragement to us. And I think we can go ahead and do this on the future days. But my questions to you, once you do clipping, at the end, most people prefer to open up the dome. In this kind of multiple clipping, how will you ensure that you have done completely why you didn't open up the dome and look inside? And especially don't see anything on the other side of the aneurysm, basilar tip aneurysm.
Well, I don't open any of my domes. There is absolutely no need for this. This is just exercise that earlier generations of surgeons used to do. And the completeness of clipping is obliteration of the visible aneurysm. So once you obliterate the visible aneurysm, I mean, if there is something filling on ICG, then you understand. But if there's nothing filling on the ICG, you're not really bothered. I mean, most of my ACOMs or PCOMs or MCAs, once I clip, then I see the flow ICG and the flow 800. And if there's no flow, then I'm kind of good to go. I don't need to open the door. But some of the aneurysms which we rupture, and there we know that unless we clip, the rupture is not going to stop. So that's one way of making sure. So sometimes we do elective ruptures for paraclinoids. Probably once we rupture it so that we can clip very fast. So if the patient is not stable or we have only short anesthesia, we do an elective rupture. So otherwise, I don't open by domes generally. I'm quite sure.
Thank you.
Okay, very good. Okay, I think
Guys, I have another meeting to attend to, so I'll have to log off. I have a meeting with Medivis, so
okay.
I need to kind of log off.
Okay, okay.
Thank you very much, guys.
We'll see you in 2 weeks.
Yeah, see you, man.
That's right. Thank you very much.
Yeah,
And
see you.
thank you, Dr. Magogo, Juma, and thank you, Dr. Segua and the residents, and Dr. Mubarak.
Othman, Juma, John,
Oh,
Shengu.